we have looked at MRD in myeloma, which is minimal residual disease. And our study, which is our largest study in collaboration with our French colleagues, where we treated patients and randomized them. Half of them received transplant, half of them received standard care, and they got maintenance. And the results of the original study was published in New England Journal of Medicine 2017. But we also studied MRD in this patient population. The MRD was measured by sequencing method in collaboration with adaptive biotechnology. And it was measured before maintenance and after completion of 1 year of maintenance, so 2 time point. And the summary of this study, which is very important impact, is number one, that if we are able to measure deeper response, better it is. And our threshold we could measure was 1 cell in a million, 10 to the power 6, and that gives us the best survival outcome. Those who can reach MRD negativity with that sensitivity live the longest. They're the best PFS. The second important message, of course, that achieving MRD negativity is very important. It improves progression-free survival by a big margin, but also improves overall survival. So in our study, we have not had many deaths yet. Despite that, our overall survival is much superior, statistically significantly superior compared to those who are MRD positive. The third important message in this study, and of great consequence in long term, is that patients who are MRD negative, irrespective of whether they got transplant or not, they do as well compared to those who are MRD positive. So the point being that it doesn't matter how you get MRD negativity, whether with transplant or without, if you get it, you have a good outcome. So what it would mean in putting into our practical term is that in future, we can decide on a treatment, and if patients get MRD negativity, we may not need to do transplant, or we may not need to do more treatment. Again, we are not ready for that decision today, but we have now studies in planning to address that question. But our current study brings that point out. And the fourth important point in this study was that patients who are either standard risk or who are high risk, but if they get MRD negativity, they have a very similar outcome. So again, that MRD negativity can overcome the poor risk associated with high-risk cytogenetics and other features. Again, it would also mean that our attempt should be to get patients into MRD negativity. The problem is that current treatment does not get MRD negativity in substantial number of patients who are high risk. So how it is going to affect our practice is that if for high-risk patient, we need to get them to MRD negativity, and we have studies in plan to do that too.